Hey, my name is Nick Selt, and I'd like to welcome you to the Journal Feed, the only place to be spoon-fed the latest and greatest of emergency medicine, where we sift through literature for the best articles summarized by our team of expert physicians to provide you with bite-sized summaries no bigger than a spoonful so that you can enhance your practice every day. Summaries this week were by Bo Stubfield, Clay Smith, and Vivian Lee. Our first article is looking at clinical pretest probability versus age-adjusted D-dimers for DVT. Korean et al. Recently published the PEG-AD study on the diagnosis of pulmonary embolism using D-dimer adjusted to clinical pretest probability. They compared the age-adjusted and year strategies against adjusting the D-dimer to clinical pretest probability and found that chest imaging was reduced using the pretest probability strategy in patients with low clinical pretest probability. Notably, the reduction in imaging for PE was greatest when the pretest probability was compared with the age-adjusted strategy. So, why not conduct a meta-analysis comparing age-adjusted D-dimer and clinical pretest probability adjusted D-dimer head-to-head in the diagnosis of DVT? And that's what this study was, a meta-analysis using an established individual patient database to compare the sensitivity, specificity, negative predictive value, and utility of D-dimer use between age-adjusted and clinical pretest probability strategies. About 2,500 patients were included in an analysis of 4 studies containing substantial heterogeneity between them. Overall, there was no statistically significant difference in the pooled diagnostic indices I just listed between these strategies, and so not enough data to suggest one strategy over the other. These findings bring home the point that clinical pretest probability or age-adjusted D-dimer interpretation has a high utility and similarly good negative predictive value when compared with unadjusted D-dimer or the standard cutoff or less than 500 nanograms per ml. So here's our spoonful. In the diagnosis of DVT, both age-adjusted D-dimer and D-dimer adjusted by clinical pretest probability were found to be similar in specificity, sensitivity, negative predictive value, and in utility in this meta-analysis. All right, on to the next. Epinephrine for pediatric out-of-hospital cardiac arrest mirrored the PARAMEDIC-2 trial. The PARAMEDIC-2 trial found improved return of spontaneous circulation, or ROSC, with epinephrine during arrest, but no benefit for 30-day survival or survival with good neurological outcomes in adults who suffered out-of-hospital cardiac arrest. A recent meta-analysis also showed improved ROSC and survival to discharge, but again, not survival with good neurological outcome. So what about in children? Did they fare better with epinephrine? This study was a nationwide Japanese arrest database of 1.2 million people, but only about 4,000 pediatric arrests in the range of 8 years to 17 years. And of this age range, more than 88% of them were above 12 years old. With propensity matching, 304 children were identified to have received epinephrine during arrest, compared with a matched cohort of children who did not receive epi. For the primary endpoint of 1-month survival, there was no difference between epi at 10.2% and no epi at 7.9%. Risk ratio of 1.13 and 95% confidence interval spanning 0.67 to 1.93. There was also no difference in survival with good neurological outcome, with epi at 3.6% and no epi at 2.6%. Risk ratio of 1.56. Those numbers aside, ROSC was better in the epi group, with 11.2 versus 3.3 without epi. Of course, we're constantly reminded that children aren't just little adults, but these findings are strikingly similar to the PARAMEDIC-2 findings. Perhaps as material for future studies were the interesting findings of a significantly improved 1-month survival as well as ROSC, and a non-significant improvement in neurological outcome if epi was given in less than 15 minutes. All said though, Clay points out some good cautionary points. This was a retrospective study, in constant danger of selection bias and other confounders. Also, this doesn't well address younger children, with a cohort primarily above 12 years old. So, in the end, our spoonful is that epi for out-of-hospital cardiac arrest in children improved ROSC, but not 1-month survival or survival with good neurological outcome. And if you're giving it, think about giving it early. And on to the next, lidocaine versus amiodarone for pediatric advanced life support, PALS. In PALS, either lidocaine or amiodarone is acceptable for shock refractory VFib or pulseless VTAC, but is one preferred over the other? This was a propensity matching study based on a pediatric in-hospital arrest registry over 18 years, looking at shock refractory VFib and pulseless VTAC. Matched were 90 patients in each group, with the only difference between them being the administration of a lidocaine or amiodarone. From this, there was no difference in ROSC, 24-hour survival, survival to discharge, or survival with good neurological outcome when comparing lidocaine to amiodarone. All risk ratios and confidence intervals were right around 1. Again, despite a large registry of over 18 years, the number of patients compared was quite small. And propensity matching does quite a bit, but confounding is still possible. In the end, here's our spoonful. There was no difference in any clinical outcome in pediatric patients with shockable rhythms receiving lidocaine or amiodarone. So go ahead and reach for either one if defibrillation fails. Our last article is 5 ways to foster a connection with your patients. This was a study identifying specific practices for clinicians that can enrich the patient-physician encounter, promote presence, and foster meaningful connection. Let's face it, connecting with patients is hard, and doing so during a brief encounter is increasingly difficult with today's electronic medical records and administrative excess. Good bedside manner is a learnable skill, though, and it can be cultivated through mindfulness and has the potential to reap beneficial outcomes for both you and your patients. This study identified 5 practices that promote presence and connection with patients. The authors initially identified practices from a literature review, clinical observations, and interviews with patients, physicians, and even non-medical professionals. The findings were then reviewed in a modified Delphi process, resulting in the following recommendations. Prepare with intention. Take a moment to familiarize yourself with the patient you're about to see. Create a ritual to clear your mind and really focus your attention before you start the encounter. Listen intently and completely. Sit down, lean forward, and avoid interrupting. Silence is a tool. Use it. Agree with your patient on what matters most. Set an agenda based on the patient's priorities and concerns. You'll see that each suggestion seems to get a little bit easier if you've already followed the others before it. Connect with the patient's story. Consider their context, their background, and their life. Be sure to acknowledge their efforts with positivity, offer praise, and celebrate small successes. Lastly, explore emotional cues. Be sensitive to verbal and nonverbal cues. Elicit the emotions you're observing and offer validation to them. These are evidence-based ways to improve the patient-physician relationship. While the systemic burdens may continue to tax these relationships, implementing a few of these strategies at the bedside can help enrich your encounters. All right, hope you're full for this week because that's all the spoon feeding we have for you. Links to all the articles summarized by our lovely authors can be found at journalfeed.org, or if you haven't already, you can subscribe to our newsletter and get these same daily spoon feeds through your email. Keeping up with research is possible, and we're here to help with one spoonful from the journal feed at a time.